Welcome back. Let's wrap up our discussions about substance abuse and eating disorders with some examples of real patients you may encounter in the field. You're dispatched for an unresponsive person, possible overdose at a residential address. On arrival, a frantic roommate leads you to a back bedroom. He says, I think my friend OD'd on heroin or something. I found him like this a few minutes ago. You enter the room. The patient is a 25-year-old male, lying on his back on the floor, not moving. You do your scene safety scan. You notice an uncapped syringe on the nightstand and some powder residue on a piece of foil. Classic opioid paraphernalia. No sign of weapons or people fighting. The scene is otherwise quiet. You put on your gloves and approach the patient. He appears pale with bluish lips. You shout, Sir, can you hear me? No response. You do a pain stimulus, a sternal rub. Nothing. He's deeply unconscious. Immediately, you direct your partner to get the BVM and oxygen. You check his carotid pulse. It's there, but it's slow, about 50 beats per minute, and weak. You look, listen, feel for breathing. He's barely breathing, maybe 4 to 6 shallow breaths per minute, essentially agonal respirations. This is consistent with a narcotic overdose. You manage the airway with a head tilt chin lift, insert an oropharyngeal airway as he has no gag reflex, and begin bag valve mask ventilations with high flow O2. His chest is rising with ventilations. Good. You notice his pupils are pinpoint, another hallmark of opioid OD. While your partner continues ventilating, you prepare naloxone. Per protocol, you have a pre-filled intranasal Narcan spray, 4 milligrams. Given the clear signs of opioid overdose and critical respiratory depression, you administer it into his nostril. You keep ventilating in the meantime. Remember, Narcan takes a minute or two to kick in, and the patient needs oxygen now. About 1 to 2 minutes after giving naloxone, the patient starts to take deeper breaths on his own. He coughs and begins to move a bit. You ease back on the BVM as he starts breathing more effectively by himself. He's still out of it, but within another minute he opens his eyes, sort of startled. He immediately appears anxious and reaches up as if to push the oxygen mask away. You calmly speak to him. Hey, you're okay, we're paramedics. You had an overdose, but we gave you a medication to help you wake up. Just take it easy. He's in that post-OD confusion. Sometimes they wake up upset because withdrawal symptoms hit quickly. He might be feeling aches or nausea now. Sure enough, he's not very happy. He groans, What? What did you do? I'm fine. Let me go. And he tries to sit up. You and your partner gently restrain his shoulders just to prevent him bolting upright and possibly falling. Just stay laying down for a minute, okay? You weren't breathing. We had to give you Narcan. You're breathing better now, but we really need to take you to the hospital to make sure you stay okay. He's agitated. No, I don't want to go to the hospital. I'm fine now. Here we face that refusal scenario we mentioned. We keep him on oxygen, now maybe a nasal cannula since he's awake and breathing, and we continue talking to him. His roommate is at the doorway looking worried. I ask the roommate to come over and talk softly to him. Man, you were out. These guys saved you. Let them check you out. Sometimes a familiar voice helps. The patient is sweating, possibly starting to feel dope sick. Narcan can precipitate withdrawal. He says he feels like he's going to puke. We roll him onto his side, have suction ready, and indeed he vomits a little, which is okay because his airway is protected and we're right there. Paramedics can and should administer Zofran 4 milligrams IV. After that, he seems a bit exhausted and less combative. We take the opportunity to convince him. Listen, the medication we gave you only lasts a short time. The drug you took might last longer. If you stop breathing again in an hour when we're not here, that could be it. We really want to get you to the ER so they can keep you safe for the next few hours. We don't want anything bad to happen to you. He finally nods weakly and says, All right. We secure him on our stretcher. Continue oxygen, monitor vitals. His blood pressure is low normal, pulse improving to 80 as the Narcan fully kicks. In, respirations now around 14 on his own. En route, we keep a close eye. Sometimes patients can go back into overdose when Narcan wears off, so we're ready with a second dose if needed. We also keep reassuring him and manage his nausea as best we can. In BLS, maybe just positioning in a basin, ALS might give an antiemetic. He arrives at the ED alive and alert enough to converse, very likely with a strong chance of recovery thanks to the intervention. Without EMS and Narcan, this young man could have stopped breathing and died before anyone figured out what to do. This scenario highlights the chain: scene safety, we looked for needles, had gloves, kept an eye on his reaction, quick ABC support, BVM for respiratory failure, specific antidote, Narcan, and then patient management post-revival, dealing with his confusion, potential refusal, and side effects. It's a real-world example of how we handle an opioid OD call. Keep in mind, not all OD patients wake up that easily. Some take multiple Narcan doses, some never really perk up if they've been down too long, leading to cardiac arrest. And not all are cooperative. Occasionally, someone comes up swinging or swearing. That's why I stress being ready for anything. In this case, it went about as textbook as possible. Now let's switch gears to our second major topic, eating disorders. You're called to a home for an 18-year-old female who collapsed, briefly unresponsive. On arrival, you find a very thin young woman lying on the floor. Her mother is there, very worried, telling you she has anorexia and she's hardly eaten anything for months. Today, she fainted when getting out of bed. The patient is conscious now, but extremely weak and lethargic. You introduce yourself and ask her name. She whispers it. You can barely hear, so you move closer, noting how cold the room feels and that she's only in light pajamas. You notice she's visibly emaciated, very thin arms and legs, her cheekbones pronounced. She's drowsy but rouses when you speak to her. She can barely lift her head. Your initial assessment, airway is clear. She's able to mumble answers. Breathing is shallow but present, around 12 breaths a minute. You feel for a pulse. It's extremely slow and weak. You count roughly 34 beats per minute, severe bradycardia. Her skin is cool to the touch, and you see she has fine, downy hair on her forearms, lanugo. You quickly check her blood glucose. It reads 35, critically low. That likely explains the collapse. Her brain was starved of glucose. You immediately decide to address the hypoglycemia. She's semi-alert now, so you ask if she can try swallowing some glucose gel. She weakly nods. You carefully administer oral glucose gel in small portions, rubbing it on the inside of her cheek where it can absorb, because gulping it might upset her stomach. Meanwhile, you have your partner prepare for transport. You lay her flat to help her blood pressure. Her mother mentions, her doctor said her heart rate was in the 40s last visit. I'm so scared. You reassure the mother that you're addressing the immediate issues. ALS providers may give a D10 bolus rather than oral glucose. This is an especially good idea if there is a concern about her swallowing. After a bit of glucose, the patient's eyes open a little more. She whispers, I feel sick. You have a basin ready in case she vomits, which can happen when a starved person's stomach gets something in it. She doesn't vomit, fortunately. Her blood pressure on the monitor is 70/40, very low. She's clearly in need of IV fluids and more glucose if a EMT with no ALS. Be sure to request backup as soon as possible. As you prepare to move her, you speak softly to the patient. We're going to take you to the hospital, okay? Your body needs some help right now. She murmurs, I don't want to, and tries to protest weakly. I'm fine. You respond gently. I know you're feeling reluctant, but your blood pressure and sugar are very low. I'm really worried about your heart. I promise we'll take good care of you, and they'll help you feel better at the hospital. The mother is supportive, saying, Sweetie, you fainted. Please let's go. The patient offers no further resistance. She's really too exhausted to fight. You package her carefully on the stretcher, covering her with a blanket, both for warmth and privacy, as she's in thin pajamas. During transport, you continuously monitor her vitals. The ALS medic starts an IV and slowly gives some dextrose and fluids. The patient's heart monitor shows a dysrhythmia, occasional PVCs, premature ventricular contractions, likely from low electrolytes. You and ALS recognize that as a warning sign for possible more serious dysrhythmias. You keep her on oxygen via nasal cannula. Though her O2 saturation was okay, it's more for the comfort and any slight benefit to those starved tissues. By the time you reach the hospital, her blood sugar has improved to 60s with your interventions, and her blood pressure is inching up to about 80/50 with fluids. Still very low, but at least trending better. She's more awake, but remains very weak. You give a thorough handoff to the ED team. 18-year-old female with known anorexia nervosa, extremely malnourished, presenting after syncope. Initial BP 70/40, pulse 34, glucose 35. We administered oral glucose and IVD10. Currently BP 80/50, pulse 40. Suspects severe dehydration and electrolyte abnormalities. Had runs of PVCs en route. She's alert to voice but lethargic. ECG on our monitor showed sinus brady with PVCs. The ED acknowledges and likely will rush labs, start controlled refeeding and cardiac monitoring, and arrange psychiatric intervention once she's stabilized. In this scenario, your actions, recognizing the severity, treating the hypoglycemia, protecting her from shock, and transporting promptly, very likely prevented a cardiac arrest. Anorexia can be deceptive. Patients may appear relatively calm or say they're fine, but internally they're on the edge. Here, by focusing on her vital signs and clinical picture rather than her downplaying, you provided the life-saving care she needed in the moment. And equally important, you maintained a compassionate, non-judgmental demeanor, which helped ensure she didn't completely refuse care. This scenario highlights how an eating disorder emergency might present: fainting from low blood pressure and sugar, and how we must be prepared to treat both the body, ABC, glucose, shock, and consider the mindset of the patient, gentle persuasion, understanding their fears. In closing, remember that substance abuse and eating disorders are complex illnesses. Our role in EMS is to treat the acute emergency, keep the patient safe, and start them on the path to further care. You won't cure their addiction or disorder on scene, but you can prevent an immediate tragedy and perhaps provide a compassionate encounter that encourages them to accept help. Every patient, whether it's someone with a substance use disorder or someone with an eating disorder, deserves our best care. By being knowledgeable, as we've gone through today, and showing empathy, you can truly make a difference. Your actions in those critical moments can save a life and maybe even be the turning point that leads the patient towards recovery in the long run. Thank you for joining me and stay safe out there.